Good afternoon, everyone. Thank you all for joining the TxRx Echo brought to you by the Center for Substance Use Training and Telementoring, also known as CSTAT, by Be Well Texas in collaboration with the UT Health San Antonio Echo program. My name is Angela Riley, and I will be the facilitator for today's session. A few housekeeping items before we begin. Please continue to introduce yourselves in the chat by entering your full name, affiliation, and email. We love to see where you all are joining from. Please do remember to stay muted unless you are speaking. However, we do encourage using the chat and or the raise your hand feature throughout the session today, so that you all can share your perspectives and pose questions. As we will have Q&A portions throughout today. So we will address those then. We would love to see everyone with their cameras on. This does increase connection and engagement, though we completely understand that some situations don't allow for that. But if you can, we'd love to see your smiling faces or not smiling faces, whatever you're feeling. If you're having connection issues, please privately chat Karen, our wonderful Echo IT, for further assistance. And as a note, these sessions are being recorded and will be shared on our website. Therefore, to ensure privacy, no personal health information will be allowed throughout the session today. This does include items such as names, addresses, birth dates, specific appointment dates, what have you, any other identifiable information. And the slide presentation for today's session will be uploaded and shared on the iEcho platform for your reference after the session, and it will also be shared in the post-session email. At the end of the session, the Echo team will be sending out a post-session survey link. We kindly ask that you all complete it as it provides us great insight on how to refine these sessions, improve them, and make them better to address your priorities and interests. And finally, Echo is an all teach, all learn environment. We encourage all of you to participate in the conversation and raise questions. May we always continue to make every effort to continue having a space that is respectful and safe for all of us to learn. With that, we'll go ahead and move to introductions. When I state your name, please unmute and introduce yourself. We'll begin with Dr. Waklu.
Hi, good afternoon. Siddharth Waflu. I'm faculty at UT Southwestern in Dallas. I am the interim director of the Addiction Division, director of the Addiction Psychiatry Fellowship here, and welcome everyone. Thank you so much.
Thank you, Dr. Waklu. Dr. Shorter.
Good afternoon, everyone. I'm Daryl Shorter, an associate professor of psychiatry at Menninger Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine here in Houston, Texas. I'm also the medical director of addiction services at the Menninger Clinic, as well as our addiction psychiatry fellowship for Baylor. Nice to be here. Thanks.
Thanks for being here, Dr. Shorter, and playing a dual role today as our lead specialist, actually like a triple role. She's also a hub member and she's our didactic presenter for today, Dr. Crystal Walker.
Hi, everybody. Crystal Walker, a doctorally trained PA and the Director of Substance Use Disorder Clinical Services for My Health, My Resources of Tarrant County, the local mental health authority in Fort Worth, Texas. Happy to be here.
Excellent. Thanks so much, Dr. Walker. And thank you all for being here. Thank you all for your introductions. Continue to drop those intros in the chat. And with that, let's get started with our didactic presentation. Dr. Walker, you may take it away.
Absolutely. All right, let me get my slides going here. So today we are going to be talking about the topic related to treating individuals who are unhoused and making sure that we're bringing empathy and trust in a trauma-informed way to help treat all aspects, but specifically focusing on substance use. I have no disclosures, and all of the speakers and members have no disclosures, and you can read the rest of that statement. Okay, so here are our learning objectives for today. We're going to start by going over a few definitions so that we're all on the same page when we dive into this topic. So, when we talk about individuals experiencing homelessness, we're talking about a person who lacks a fixed, regular, adequate nighttime residents. Okay, so that is the definition developed by the annual homelessness assessment report that is given to Congress every year. Now, there's two other main categories. One is sheltered homelessness. So this is going to refer to individuals who are staying with a roof over their heads. So in emergency shelters, transitional housing programs, safe havens, those types of places. And then we have unsheltered homelessness. These are individuals whose primary nighttime location is in a place that's not designated for staying there. So, in a car, in a public park, an abandoned building, bus or train station, those types of locations. And then chronic homelessness is defined as someone who has experienced being homeless for a year or longer, or who have had 4 episodes or more in the last 3 years. And then a term that we're going to address a couple of times is rapid rehousing. So, this is a housing model that's designed to provide temporary housing assistance to get people into permanent housing with assistance up front, but that they'll be able to remain once that assistance ends. So, one of the main things that the annual homeless assessment report does is on a single night, a single point in time, they have a mass mobilization of volunteers to take an account of that moment in time, how many individuals are unhoused. And this graph shows the report for the last several years. One of the key things that I want you to note is, of course, we all know that statistics around 2020 and 2021 are greatly lacking. But when the statistics picked back up regularly in 22, 23, and then specifically in December of 2024, we have had the highest ever recorded rate of homelessness in the United States. And you can see the last 3 years how much this has absolutely skyrocketed. The top line is referring to all individuals experiencing homelessness during this point of time count in December of 2024. The second line is those individuals experiencing sheltered homelessness. And that line also was a dramatic increase. Unsheltered homelessness didn't increase as dramatically. So, when this homeless report was provided to Congress, they wanted to dive into what are some of the factors that could have been contributing to this very steep spike in increased numbers of individuals experiencing homelessness. And here are some of the main contributing factors that they came across. Well, worsening national affordable housing crisis, rising inflation, stagnating wages, public health crises, natural disasters, and then two other ones that play a big part too. The end to the homelessness prevention programs that were put in place during the pandemic and the end of the expanded child tax credit both played key roles in this number skyrocketing. So, we know that there are more individuals experiencing homelessness than ever before in our society. So, what can we as frontline workers do? Well, one, we've identified someone who's experiencing homelessness. During that first visit that we find that out, maybe not the first visit with the patient, but the first visit in which we learned that information. This is the point in time where we really want to dedicate some time to identifying the patient's main priorities. And I want to emphasize that because unhoused individuals tend to have multiple health conditions, higher rates of substance use, higher rates of mental illness, higher rates of comorbidities impacting their health. But this is competing with non-medical priorities that the patient may have. And if those priorities cannot be addressed and shared and barriers addressed, then there is no progress going to be made on either the frontline staff priorities or the patient's priorities. So, coming together to establish those shared priorities is going to be incredibly incredibly important. And we should be doing this in a trauma-informed way. So, the graphic at the bottom, if you're not aware of the six principles of trauma-informed care, and there are multiple information packets out there and classes that you can take to establish your organization as being trauma informed. But essentially, these are the six principles, right? Creating a physically and emotionally safe environment for all of the individuals that are coming through your clinic. Establishing trust, being open, honest, and consistent with your interactions. And then fostering a sense of community and belonging through peer-to-peer support, including individuals with lived experience as part of the treatment team. And then working together with individuals and communities to share that power and that responsibility, while respecting an individual's rights and providing them with opportunities to make informed decisions about their own care. Because when the decision is informed and they are making it, there is going to be more motivation behind that. And then recognizing and addressing the unique experiences of trauma based on cultural, historical, as well as gender factors. So, when I have referred to clinical prioritization versus the patient's priorities, these are some of the elements that I am addressing. So, we know that cardiovascular disease is the leading cause of death among people experiencing homelessness. So why is this? Multifactorial issues involved here. Poorly controlled comorbidities, higher rates of risk factors such as substance use disorder, smoking, chronic stress, mental illness treated with antipsychotic medications. So when we look at the smoking and tobacco use, an interesting statistic that was found is that out of individuals experiencing homelessness, 70% of them are typically tobacco users, and that is compared to only 13% of the general population. So, this is contributing to those comorbid issues. And also, individuals who are homeless experience a disproportionately high rate of substance use. Now, one of the myths surrounding this is kind of a chicken and egg situation, right? There is a lot of stigma around being homeless, as well as a lot of stigma around having a substance use disorder. And many individuals believe that the substance use disorder is what led to or caused the individual's homeless status. But in actuality, a study that was done by Johnson in 2008 found that out of individuals experiencing homelessness who've been diagnosed with a substance use disorder, two-thirds of them developed the substance use disorder after becoming homeless, not before. So, why is this? There was a lot of correlations found. You know, they are typically more isolated. Experience a loss of self-worth. They may use it to ease physical pain as well as mental anguish. Just generally coping with the demands of living without a permanent home, as well as idle time. Idle time was one of the big focuses of this, where there is a lot of waiting in between tasks when you are trying to transition from being unhoused to getting a job and being housed. If you lack your critical documents, there can be a huge waiting period between getting an ID, getting your birth certificate, and you can't get a job or get a home or get into programs until you have those things. So there's a lot of idle time on their hands, and this isn't them being quote unquote lazy. No, this is out of their control. And also because of multiple of these barriers, a lot of individuals who are unhoused, even if we are able to identify them and attempt to enroll them in treatment, they tend to disengage with substance use treatment after that initial encounter. And some of this can be, of course, due to all of the barriers. This can also surround them not having the current desire to stop the use of substances, right? Their motivation is different than our motivation. Their goals is going to be different than our goals as a treatment team. And this can be due to them coping with trauma, stress, the adversity that they're under. And this is why some programs, such as abstinence-based treatment first housing, really just creates additional barriers to trying stabilizing individuals experiencing homelessness. Because, as we've already established, individuals who are homeless experience higher rates of substance use, mental health, and physical health concerns, but they end up having some of the lowest rates of screenings, lowest rates of routine follow-up. So, what are some additional barriers to this that we haven't already discussed? Because we already discussed a lot of them. Some of them are their priorities are finding food and shelter every day. If you do not have adequate food and shelter, that can take up the majority of your time. There's a lot of experiences in the negative, right? A lot of perceived prejudice, negative experience with the healthcare teams using stigmatizing language if they miss an appointment or if they don't take their medications, they're non-compliant. And instead of digging into, well, why didn't you take your medication? Oh, was it because a side effect was diarrhea and you have no access to a bathroom, so you don't want to be vulnerable when you are unhoused? Okay, that's a barrier, not non-compliance. And those are the types of approaches we need to take when treating individuals who are unhoused. So, what are some interventions that can really benefit someone who is experiencing homelessness? One of the main ones is housing first initiatives, right? The rapid rehousing. This is immediate, permanent, low barrier, non-abstinence based supportive housing for individuals. This has been shown to be very helpful with stabilization, right? Now, a key element in some of these studies, especially the Miller 2021 study, is that there really wasn't a positive or negative outcome. So, a less statistical impact on substance use outcomes with housing. This is why there's a focus on it being non-abstinent based, because if this is your only intervention, you're unlikely to have a major impact on improving or decreasing the use of substances. That's why we have to pull in a more integrated approach, incorporating things like case management, providing outreach, assessment, planning, monitoring the patient more closely, having advocacy services. This has statistically led to a reduction in substance use, as well as providing medications for substance use treatment. But again, make sure you have a shared goal with the individual that you're treating. The focus should really be on retention with individuals who are rehoused, making sure they still have the ability to follow up, to engage with the full treatment team. Then incorporating peer support. This has led to an overall reduction in harm related substance use. In intentional peer support, that is organizationally based, making sure that there's access to all of the services and education that are needed to support these peers. Then harm reduction strategies, of course, lead to better outcomes in combination than just single interventions. So if you combine education with naloxone, with access to clean water and clean items and safe injection practices and never using alone practices, when they are all combined, they are going to have a more statistical impact. And then emergency department initiatives that have been really effective are things like critical time intervention and assertive community treatment. Again, those two things can be full lectures on their own, but I want us to be knowledgeable about what interventions have evidence backing to be effective, as well as sex health promotion. This increases the knowledge of drug-related harm and it will initially lead to a reduction in substance use. Now, long term, so over 24 months, over 2 years, the results are a bit mixed, but early on for early stabilization, this can be very impactful. Now, when we're talking about substance use treatment, we have to address opiate use disorder, especially in the unhoused population, and buprenorphine. In my experience, many prescribers are hesitant to provide buprenorphine to individuals that are unhoused. And one of the biggest reason is a fear of diversion. So, a study from Rubel in 2023 showed that diversion among people who are in treatment topped out at 4.8%. And the studies have consistently found that the main reason for diversion is self-treatment, managing withdrawals, cravings, bridging to care, and those types of items. So diversion does not always equal quote unquote getting high. Okay. So again, we need to focus on access and dose optimization rather than fear. And unobserved induction, most often referred to as home reduction, but when we're discussing this with an unhoused individual, it is better language to say unobserved induction. And that is something that is absolutely successful, even with working with unhoused individuals. Now, when you're prescribing, what are some medication considerations that you need to think about? So, as I've discussed before, getting information is going to be key. Do they have storage? Do they have access to a fridge? Do they have access to food? You know, if they're diabetic and they don't have access to a bathroom and they get metformin that causes diarrhea, that can be a problem. Or if they don't have access to a refrigerator, is insulin really the best option? Do they have access to water, restrooms? And then storage is going to be a big one, right? Because individuals who are unhoused are at huge risk of all of their belongings, not just controlled substances, but all of their medications, high blood pressure medications, any clothes, any shoes. They are at risk of all of their items being stolen. Um, an individual who works in street medicine once told me that trying to avoid things being stolen when you're unhoused is like trying to run through the rain without getting wet. It is almost an inevitability for these individuals. And so that needs to be a consideration. So, you know, when you're prescribing things, looking at things that are going to make them more vulnerable, like sedation, nausea, increased urination, increased diarrhea, and then what are some strategies that we can deploy when regarding knowing that at some point their medications are likely to be lost or stolen? So, some mitigation techniques that can be used is if you have the ability to store items in your clinic. Most clinics don't have this due to risk and liability issues. So, some other factors are even if they can't live with or they're not allowed to live with friends or families, would their friend or family allow them to store their medications there and come by once a day to get their medications dosed so that it's in a safe area? If none of those are options, then one of the biggest techniques that I've experienced is they keep it on their person. They keep their medication in their pocket of their pants, in their pocket of their jeans on them, not in their backpack that gets laid down that can get left on the bus or somebody can take, but they keep it close to their body. Um, and then making sure that you plan ahead, discussing with individuals who are unhoused. What is the strategy if this buprenorphine gets stolen? What are we going to do? Right? One of the ways that we have addressed this is by getting a police report and being able to turn that police report saying that their medications were stolen into the pharmacy can sometimes allow for you to get an early refill for that individual. Now, it doesn't always work. So there are some other strategies that you can come up with, such as optimizing your refills, right? If they're at high risk of their medications being stolen, then you may not want to prescribe a month at a time because if they get a whole month stolen, that's going to be much more difficult for them to bridge that gap until their next refill versus a week or 2 weeks at a time. And then again, creating lower barrier access, walk-in clinic times for individuals who are unhoused. What's interesting in my area during our community meetings that we have once a quarter, One thing that keeps getting brought up in our area is installing a clock. Installing a clock in the area where a lot of the unhoused individuals gather for resources, because we have multiple shelters and multiple clinics all in one area dedicated for treating the unhoused. Yet many of them don't know what the day is, don't know what the time is. They cannot keep an appointment. Lack of transportation and not knowing what day and time it is creates a pretty huge barrier with keeping appointments. And so just being aware of that and having some decreased low barrier access can be incredibly valuable for someone who is unhoused. So that was a lot to cram into a little 20-minute talk. So I want to leave you with two things. Number one is creating integrated services. And I am emphasizing integrated here. You want everyone to be on the same page. You do not want to have the patient to have to explain their entire situation to the case manager, then the pharmacist, then the nurse, then the primary care provider. You want to team together, all be on the same page, and all help come together to help this individual. And everyone has an incredibly valuable role in treating unhoused individuals. And bonus points if your organization has access to dental providers, outreach workers who can go to the camps and go to the place where the client who is unhoused physically is, and harm reduction specialists. We're not all lucky to have that, but if we do, absolutely engage those individuals as part of a treatment team with someone experiencing homelessness. And then I want to leave you with a couple of resources. Hopefully, we can put a couple of these in the chat. One of the big ones, especially for my prescribers on the call, is the National Healthcare for the Homeless Council has an Adapting Your Practice for Homeless Patients series. This series is excellent. It has multiple modules and diagrams and workflows for diabetes mellitus, communicable diseases, asthma treatment, HIV, cardiovascular disease, the unique barriers and the unique treatment approaches that you can have for each one of these main medical conditions, as well as general recommendations that will go into way more in depth than I was able to on today's talk. All right, and here are my references, and I am ready for any questions that may be out there.
Excellent. Thank you so much, Dr. Walker, for this wonderful, holistic view, rich presentation. Thank you so much. And I open the floor to any questions and comments from anyone on the call today.
So, since no one's asking questions, I'm going to give an answer to a question that wasn't asked. So, individuals who are keeping their medications in their pocket, those medications are going to be exposed to the elements, right? They're going to get wet. The label is going to rub off. The medications, if you're prescribing buprenorphine tablets that are oral disintegrating tablets, they're going to get crushed up. So, some of the practical things that we do is provide cotton to fill the empty space of a bottle that's going to be kept in a pocket. Provide packing tape that can be put on the label of the bottle so that the label doesn't disintegrate. So that if they do have an encounter with an officer and they say, hey, this is a controlled substance that doesn't have your name and doesn't have a prescription, that they get in trouble for having that. So keeping in mind some of those practical things that we need to consider with Unhoused is also really important.
Thanks, Dr. Walker. And I do see that Jasmine, the coordinator for this really great echo, shared those resources that Dr. Walker had in her slide, but as a note, those will also be shared um, as well. And Elizabeth Sanders says, thank you, Crystal. You hit the nail on the head. I wish every person could have heard this talk. Yes. Oh, and claps, yes, from Elizabeth as well. I actually had a question for you, Dr. Walker. For those moments where you talked about the internal team sharing, the the story of the patient or client, just so that that person doesn't have to keep repeating their situation again and again. What does that look like for your team, or what have you seen teams do to kind of internally get on the same page?
So us internally, we implement teaming a lot, right? So every morning, no matter what, especially in our residential program, we are getting together all of the LCDCs and the nursing staff and the prescriber and the residential technicians, and all of us are getting together to discuss these cases. So that we can come together and say, hey, this individual may need transportation on this day to this thing. And then who can help us coordinate that? Who can do this? And we're assigning tasks to individuals as well as making sure that it's not having to be repeated over and over again. Also from a prescriber standpoint as well, when we do our visit with those individuals, there is so much stigma around individuals being homeless, not having access to appropriate showers, maybe wearing more clothing than other individuals are wearing. So physical exams can sometimes be traumatizing for these individuals. And so, again, making sure that we're having that trauma-informed approach, any encounter that we have. And then I feel like I saw Cynthia try to raise her hand and talk.
Oh, yeah, thank you. I wanted to ask, I couldn't figure out how to use the raise hand on my Zoom thing. I wanted to ask if there, I don't know how to word this, are there priorities that you've seen working with these individuals around their treatment plans that are different from other populations that you can speak to?
Absolutely. And it is so variable. It is so variable because they are in a constant state of heightened stress and just survivor mode most of the time. And so we could be having a very in-depth discussion about the fact that they just had a major overdose, that we want to get them started on buprenorphine, all of this. And their main priority is calling their daughter that they haven't spoken to in 5 years, right? Like they're going to have a completely different priority than maybe you have. And they're unable to focus on any other priority than what they have right then. So sometimes you have to pause that conversation. And even though you don't feel like it's a priority, it is such a priority for them that you have to address it in the moment so that they are then open to moving on and addressing some of those other items. Yeah, so it's very variable. I've seen, making sure that their, old neighbor's dog has food to, I need to go cash this check that I've had in my pocket for 3 months to, things that will sometimes seem illogical to us, but that it is their priority right then.
Thank you.
Really great question, Cynthia. Thanks, Dr. Walker, for responding. And to echo what Sonia shared in the chat, you have to meet them where they're at. That's at the core of it also. Dr. Waklu, I see your hand is raised.
Yeah. Dr. Ahmed, that was an outstanding presentation. That was so much information and very considering the fact that, you know, having medication storage issues. So clinically, your goal would be as much as possible, of course, it's not possible, is to have them on injectable or long actings that they don't have to carry medication. But in the state, how much resources do you have to be able to provide Sublocade, Vivitrol, Maintena? And that's my question. Do we have the ability to have as much as possible practically for people who are unhoused to have long-acting injectables?
Excellent point. And I agree with that sentimentality wholeheartedly. Lowering that barrier to make things like Sublocade, right? An injection can't be stolen. You can't take that from somebody. And it is critical. We were lucky enough a few years ago, we actually wrote a grant specifically for Sublocade. Now, the unfortunate thing about grants is that they're time limited. So it only lasted for a couple of years, but we saw how important that was and how successful that was. But as far as the state of Texas, there isn't really a standardized here Sublocade. And there's two main reasons for that that I've come across. Sublocade isn't on the formulary for HHSC. So number one, it not being on the formulary means that they will tell you the answers that I've personally been given is, well, we're giving you money for OBOT, right? Or whatever program that you have that's state funded or publicly funded. Well, we're giving you this set money. You can provide whatever formulation of buprenorphine that you want, which is out of the realm for what we're getting reimbursed to then provide that for the patient. But I fully support advocacy for increasing access to those things.
Thanks, Dr. Waklu. And as Esteban Romo added, we have to meet them where they're at, but also not leave them there. And I think echoes like this really help us get creative on how to lift people up in their healthcare. And Kaylee added, I have found that case management is an invaluable component of the multidisciplinary team. Helping address non-medical needs in addition to the medical psychiatric can help make such a difference. And that is so very true. Our case managers do so much and manage, no pun intended, manage so much. So they're invaluable. They're really great. Thank you all for your thoughts and your perspectives on this, and thank you, Dr. Walker, for your presentation once again. At this time, we'll go ahead and move over to our announcements. Karen, if you could please share those announcement slides. Thank you so much. Awesome. So to claim your CME credits for today, please ensure you have a registered account and then text attend 101-00878 to 844-502-1338 no later than midnight tonight. We want to remind you all that completing these post-session surveys, they do help shape the sessions around your needs, your interests, as the series was created for you all, and your feedback truly does matter. Your ideas and experiences and suggestions really guide how we plan future sessions and our future curriculum. And so we kindly do ask you all to complete those post-session surveys because we really do use them in our planning for the series. Next slide, please. CSTAT offers you all the wonderful opportunity to present any challenge your organization is encountering and to receive live feedback from our hub of experts and the broader learning community. There's no need to prepare a formal presentation as we provide you with the case form itself to fill out to assist you with your case presentation. Please email us using the link in the chat if you're interested or know someone that might be interested in presenting a case at a future session. Next slide, please. The Center for Substance Use Training and Telementoring by Be Well Texas is still accepting applications for the Mood Mentoring Program. This is an exclusive opportunity for the Texas Public Health Region 8 prescribers to receive personalized one-on-one mentoring to integrate mood services into their daily practice. If you or a prescriber you know in Texas Public Health Region 8 might be interested in participating, we encourage you to visit the application link that will be shared in the chat or to reach out to us using the email that will be shared in the chat. Next slide, please. And with that, please join us for our next session on September 25th, where Dr. Chowdhury, one of our wonderful hub team members, will be the presenter. Thank you, Karen. And at this time, we'll go ahead and move on to our case presentation for today. Kaylee, once Karen shares the case, please introduce yourself to those on the call and walk us through it. Thank you.
Great. Good afternoon. I'm Kaylee Dozier. I'm Joachim. I'm a psych nurse practitioner and I work at Healthcare for the Homeless Houston. And today I wanted to discuss a patient I've been seeing for a little while, but she's a 39-year-old female with a long history of polysubstance abuse. Her heavy use began in 2012 after the stillbirth of a child, which she describes, as a turning point in her, use of substances. Since that time, she's been in and out of various treatment programs, with her longest sustained period of sobriety lasting about 18 months. Her primary substances of choice have historically been alcohol, benzodiazepines, which she often purchased on the street. She's also struggled with intermittent, or intermittent prescription opioid use, starting with her own prescriptions and later taking her mother's medications. Over the years, alcohol has, typically remained her most consistent and problematic substance, and that ended up leading to strain in her marriage and divorce. She's faced a lot of significant legal consequences, including several DWIs and probation. Following her third DWI in August 2024, she lost her job as a teacher at a charter school and has had minimal contact with her children since that time. Around that time, she was living in her car and experiencing, homelessness. And I started seeing her shortly after that period. She was required to have an alcohol ankle monitor placed by the court system, which prevented her from drinking, but led to her beginning to use benzos, methamphetamine, and opioids more frequently. In February 2025, she was started on Suboxone for opioid use disorder. Shortly after, she developed swelling in her lower extremities, 1+ pending edema. Workup included labs, medical consultation, and her Suboxone eventually was, switched to Subutex because of that. And she's been tolerating that well. In March 2025, she did have a brief incarceration in Harris County Jail, and she wasn't, unfortunately, continued on treatment during that time, or her psychiatric medications. And so she did, have to go through withdrawal during that period. After her release, she was charged with a shoplifting case, and she herself notes that she struggled with impulsive behaviors throughout her life. She is currently involved in the felony mental health court system through Harris County and is required to live in sober living as part of that treatment plan. And at present, she's working about 4 to 5 days a week at Denny's, meeting regularly with one of our LPC, LCDC providers, and attending 12-step meetings, meeting with her sponsor. She is currently in a fairly turbulent relationship with her fiance, who does continue to use substances intermittently, which poses some risk to her recovery. Despite these challenges, though, she has been engaged in treatment. Again, she's tolerating Subutex 16 milligrams daily and maintaining some stability with a structured environment. Her urine drug screens have been negative for all substances other than buprenorphine since she began medication-assisted treatment. And, other than taking that, she's also getting now Abilify Maintena. She's on 400 milligram monthly injection for bipolar disorder. Takes hydroxyzine as needed, primarily at bedtime. And then she's also, again, being followed by medical, taking a statin for her hyperlipidemia. She's also on Trulicity and metformin for diabetes, excuse me, and gabapentin, 600 milligrams BID. So as far as her current treatment plan, again, we've continued her MAT treatment with buprenorphine for opioid use disorder, and given her intolerance previously in the resolution of the edema, encourage continued abstinence from alcohol, continued engagement again with the additional supports from LCDC, LPC for counseling, and emphasizing relapse prevention, maintaining her structured living environment and the sober house that she's staying in currently, and participating in 12-step programs. And then obviously there's some support too with the felony mental health court that requires frequent updates and correspondence with the counselors that work in that program. So my questions for everyone, regarding this case in particular would be one, how do others approach treatment when alcohol is the primary substance of choice, but also, patients are using other substances and sometimes have to substitute, when alcohol is restricted. I don't know if a lot of people have had experience with the alcohol monitoring. I know it seems to be done, I haven't seen it too frequently, but if others have any experience with that, what strategies do you use when patients experience side effects with buprenorphine naloxone formulations, and how do you determine when to switch to a mono product or alternative medication? Has anybody else kind of experienced any of that? And also given, just her history of trauma, impulsivity, current, relationship strain with her partner who is actively using, what approaches have been effective in keeping patients engaged in treatment, reducing relapse risk? So those are just, some questions. I could probably ask more about her in particular, but, thought that would be a good place to start for discussion. So.
Excellent. Thank you, Kaylee. And yes, these are great questions. I open the floor to our hub team in case there are any follow-up questions, and also to the members on the audience members if they have any questions. And I'll pass the mic to Dr. Walkley to get us started.
Kelly, that was an excellent case presentation, and really a very complex case that you have managed very well, and so that is a beautiful job. How are you ensuring? I just have some follow. How are you ensuring compliance from alcohol? Is it self-report? Are you checking urine, ETG, ETS? Are you doing a serum breath analyzers? Yeah.
So we currently in our clinic are not monitoring any of that, but she does still have the SCRAM monitor placed from the court system. So as far as I'm aware, that detects any type of alcohol, even if you have to avoid using, anything that contains alcohol, mouthwash, so on and so forth. So that has been placed by them. So we haven't specifically monitor that because she has that monitor in place. But yeah, if she didn't, we could, check that way, like with either, like you said, breathalyzer or, checking urine. But because she has that monitor, we just kind of rely on, that to kind of keep track.
Thank you so much. And the switch was made to the mono product was primarily because she complained about edema.
Yeah, and I had talked with her primary care provider. She had some lower extremity swelling. And I think when I talked about it in the case study, it may have been a little confusing, but she actually noticed that it was, reduced when she was, taken off the medication in Harris County Jail. Like when she went through withdrawal, we started her back. It was, like she had the edema back again. It wasn't severe, but it was bothersome to her and it was concerning for her. And there hadn't been any other changes to her medications. Labs looked, fine. There wasn't any kind of other thing that stood out for that. I know I looked up several case studies. I couldn't find a ton of information, and there's little on like kind of that naloxone sensitivity, not like a true, I guess just more of that sensitivity. But since switching to the mono product to doing Subutex buprenorphine on its that's all resolved. So I just that's what we decided to try, and that seemed to be helpful for her.
It's always a red flag for me, when patients specifically come to clinic or for a knee evaluation and say the only thing I'm going to take is the mono product. So that's sometimes a red flag. Of course, as you know, abuse potential for bupe is low, and whether the mono product or the combination, no question about that. But in Finland, they've had a lot of issues with buprenorphine abuse for some reason. It's very unique. And when they did studies about drug likeness between the combination product versus mono product, there was more drug likeness for buprenorphine mono as compared to the combination product. But that's just like one study in one country. And so again, if people, like I said, I clearly bupe is a great medication, works very well for our patients. Abuse potential is low, but if people are going to abuse something, it's more likely be Subutex than Suboxone. So that's sometimes a red flag for me. I do switch people over, primarily patients who have been stable for a long time, and cost is an issue because there is a cost. The patient will come back and say, Dr. Wafu, the mono product is much cheaper. Can you switch it? And for stable patients, I do switch it, but that's again,
no, I agree.
Yeah.
And we did discuss this a lot as a treatment team and with the other providers. So, and I will say, so obviously, as far as, treatment with Suboxone is relatively new. She has been established as a patient, like on and off for about 5 years, seeing primary care. So new to me, but she is, has had a relationship with the clinic for a long time too. So that kind of, made a little, like, we kind of discussed what we should do. But I agree. I had that kind of same hesitancy and like just concern. And that's why, again, I thought it would be good to get feedback, because it's not something that I've seen a lot in practice. And also, like, again, couldn't find a lot of information about it, just like a couple case studies.
So, anecdotally, from my own personal experience, we used Suboxone name brand films for a long time in our facility, and we did see quite a few cases in our residential detox facility of new onset lower extremity edema that seemed to coincide with the buprenorphine dosing. When we financially had to change from the films to the tablets, those incidences greatly reduced for some reason. Again, there's not a lot
She
of
was on
correlation.
film, so that's an interesting thing that, yeah.
Yeah, so it's again purely anecdotal, just from my own personal experience. It seemed to have a higher incident rate of the lower extremity edema with the films than with the tablets, even comparing bup naloxone in both. They wouldn't have the same amount of edema with the sublingual tablets as with the films. Just a little aside.
Thanks, Dr. Walker. And yes, go ahead, Dr. Shorter, please.
Yeah, really excellent case presentation. Thank you so much for sharing this with us. I just was thinking about on the medications for addictions treatment side of things, when someone is also struggling with alcohol use disorder, other options, of course, could be disulfiram antabuse or acamprosate. I know that the patient is also taking gabapentin, which can, for some people, reduce anxiety. And to that end, I wanted to make sure I loop in a couple of questions about from a psychiatric standpoint, what are we looking at in terms of current symptoms in comparison to past or previous symptoms? The only medication that you'd indicated she was taking in addition to the hydroxyzine was the Abilify Maintena. And I was wondering if that was holding symptoms of both bipolarity as well as mood instability at bay. How's she doing in relation to like trauma symptoms? Recognizing that, of course, worsening psychiatric symptoms could put her at risk for recurrence of substance use.
Mhm. I mean, overall, so she's been on the, long-acting injectable product for about 2 months. So what part of that was when she did go to the county and she didn't have like they weren't providing any of her medications. She was, wanting to switch to something like a long-acting injectable and just kind of reduce some of the oral medications that she was taking. So that was kind of made in, part with her kind of her preference. Um, I would say that she's doing, fairly well. There's a lot of, again, strain relationship wise and some other, factors, but no instances that, we've seen of kind of any mania in the last, like, several months. She did have that episode after she got out, and whether, I mean, she was, there briefly, but not being, on any medication option. She has in the past been on, a more traditional mood stabilizer in combination, but has, felt that she has experienced, side effects with several medications. So that is why she's currently only on, Abilify Maintena just as a mono. And just kind of wanting, she wants to reduce medications, obviously, just kind of monitoring that closely. So I do see her fairly often, and I talk with the LPC, LCDC who sees her as well. We kind of, kind of work together just to kind of make sure that there's nothing that we're seeing that's concerning.
Active
Um,
symptoms.
yeah. So.
The only other thought that I had, and we sort of talked about it when we were reviewing the case ahead of time, is for BPD, it responds so well to dialectical behavioral therapy. So maybe DBT could be an
Mhm.
option for her. as well as for the history of trauma, something like a cognitive processing therapy or a
Mhm.
prolonged exposure, especially in cases where people are not necessarily interested in going on to more medications or making changes to their medication regimen. Uh, it sounds like you
No,
all are
she
also
would
doing a lot of work.
definitely benefit from DBT. I agree 100%. The biggest challenge I found with that is obviously she's uninsured, and I know that they have they did have the IOP program at Bentob, but we don't work directly with Harris Health. We're an affiliate of them, like so we do use share a medical record. But I've been trying to navigate for a couple of patients, trying to see how I could get them referred to that program. The DBT IOP program at Bentob, because that's really the only option that I'm aware of for people that don't have commercial insurance or can do self-pay in the Houston area. And I know you're in the Houston area too. I've heard great things about that program, but just getting the, contact so that we could, maybe refer and we get people set up with a gold card so they can see, Harris Health providers too, to maybe have that option to do that program because I think it would be good.
I'm sending a couple text messages now.
Okay.
Can you please
Okay.
put your information in the chat? I'll follow up with you.
Sure. Mhm.
That's why we have the hub,
Thank you.
y'all. This is awesome. We'll see if we can get you linked up with somebody over there.
Excellent. Thanks, Dr. Schroeder. And yes, this is what these sessions are about, that resource sharing, especially when we share where we are locally and regionally. It's very helpful. So we're always happy to see that happen in sessions. Any thoughts from our audience members before I pass the mic to our lead specialist for a summary of the discussion?
While we wait on a question, I do have a clarifying question. So, in the last 6 to 7 months since she's been on the buprenorphine, except the blip when she was incarcerated, she has otherwise been without any of the other substances. She's tested
Mhm.
negative on all UDS, her scram monitor,
Yep,
measuring her
she has.
perspiration
Since she
alcohol,
started
all negative.
treatment, she has, and historically she would test positive intermittently for benzodiazepines and sometimes stimulants. But since she has maintained just only positive for buprenorphine, and even after she got out, I mean, she came right back into the clinic, and I mean, no relapse there either.
Yeah, because there are several studies out there that essentially say, when you have co-occurring substance use disorders, such as alcohol and opiate use disorder, and you put them on buprenorphine, the alcohol use disorder does have a chance to improve simply from the engagement and retention in treatment and getting those wraparound services. So, since the patient is stating, hey, I don't want to take any more pills, like I'm sick of all of the medications that I'm taking, it sounds like being on the buprenorphine and staying engaged in services has had a positive impact on her alcohol use and her other substances, which is excellent.
Definitely. I've seen a big difference from, before versus after.
Thank you. Thank you all for your thoughts, your insights, and to Kaylee for presenting this really rich case to us today. And we hope it inspires anyone else in the audience to reach out to us and also present a case. And hopefully we can also learn from you. Dr. Walker, I'll pass the mic for a summary of the discussion today.
Absolutely. So, today was all about integrating care, taking a multi-team approach, and meeting clients where they are. So, our didactic and our case presentation had a lot of elements in combination with each other, which complemented today's lesson perfectly. So, Kaylee presented on a 39-year-old female who has had periods where she has not used, 18 months being her longest period of abstinence. And in February, she was started on buprenorphine. And since that time, it seems as though she has been rather successful in her treatment, staying engaged in services. Some of the items that we discussed was dealing with side effects related to prescribing of buprenorphine with naloxone formulations. It was brought up about when it might be appropriate to switch someone from the dual product to the mono product, and how this is really okay, especially when people are established patients and they are more on the stabilized side of items, and all other elements have been exhausted when evaluating for those side effects. And then, of course, we talked about some of her urine drug screens being remaining negative or non-unexpected results, positive for buprenorphine, negative for all other substances. Um, Dr. Shorter brought up addressing her psychiatric conditions, recommended referring her to DBT or CPT, and has offered assistance with getting you set up with some referrals. And so, if anyone else in the Learning Network has connections at Ben Taub for their DBT IOP program, Kaylee would greatly appreciate that, because that's what we're here for, to work together as a community. So, that's our case for today. I appreciate everybody being here.
Awesome. Thanks, Dr. Walker. Special thank you to our presenters today, Dr. Walker, Kaylee, and to everyone that attended the session. As a reminder, to claim your CE credit, you must text by midnight tonight. Text attend 101-00878 to 844-502-1338. And we also kindly request that you complete the post-session feedback survey using the link that was shared in the chat. We look forward to seeing everyone at our next session on September 25th. Have a wonderful rest of your week. Thank you.